And so what I see in the innovators who are really successful is there are often routes back in if you're willing to take. For that to happen well, you need several different groups of people to get on board. I think the main thing is curiosity. The evidence from the innovation literature says the people who are successful have differentiated partly on product, but mostly on.
Hello everyone, welcome back to the More Than Medics podcast. Today we welcome Dr Rishi Das-Gupta. He serves as Chief Executive at the Health Innovation Network for South London, having also served as Chief Innovation and Technology Officer at the NHS Trust Level. Rishi has extensive experience in consulting, large-scale health system transformation, and pushing for real change in the NHS. Today, we dissect what it's like leading innovation from the front and the many responsibilities a chief executive needs to navigate. Found this chat really interesting and we hope you do too. Enjoy. Welcome, Dr. Rishi Das-Gupta, to the podcast. So lovely to have you on. Thank you for making the time. We really appreciate it. Just to start, could you just give a brief sort of précis to your journey so far and where you're at now?
Yeah, sure, Martin. I would characterize it as a bit non-linear, but basically I started out in training in medicine. I did my intercalated degree in law, largely because I found quite a few of the courses actually quite interesting, and many of them, like the constitutional and the international, were things that I was interested in. But actually, I a bit like the contract and the tort law I've used on occasion as I've gone through my career. And then I qualified in around 2000, did my what were back then house jobs, so before the current foundation schemes, and got involved through that process in the junior doctors contract renegotiation and the implementation of that down on the south coast. So I guess I was, in a way, the BMA rep down on the south coast and for that implementation, and that got me involved with the management of the hospitals, which back then was predominantly non-clinical staff running the hospitals. But what I think I hadn't appreciated in that junior doctors contract renegotiation was that we went from very long hours with a lot of continuity of care and continuity of teams to a much more fragmented system where we moved to partial shifts and full shifts. And that meant that I'm not sure that any of us really had appreciated how much change that brought on the processes that we would need in the hospital. So I got quite involved in the how do we redesign processes and handovers to try and make that safe and actually to make the job, doable in a way and more interesting and fun. And the hours clearly improved, but I think in some other ways, some of the continuity and the interpersonal interactions that we had with each other were a little bit less a tried and tested method, and we had to put more stuff in. And that's where I got involved in management. So whilst I was doing my junior doctor's jobs, I was involved with things like the pharmacy committee and bits that were within the hospital on the management side of it. And at that time, people used to look outside healthcare and say how good things were in other industries in the wider world. And so I was, you hear these myths, don't you, about how the grass is greener and how things are done better in the private sector, and you still hear these things, right? But at that point, I got quite keen to see what was out there, and I had this plan. I talked to all my friends from med school who, by that time, they'd done their degrees when I was doing my preclinical, so they were there sort of about 5 years, 6 years into their careers, found out a bit about what they did in lots of different fields. And some of them had done management consulting. So I made a switch from clinical medicine into management consulting. I actually did it pretty much full time initially, with a plan to do it for 2 years, gain some skills, probably cheaper than an MBA, and come back to do medicine again, but with a view that I might be interested in the medical management side of things. So that was my first step out, and that was about 2 years. I did that full time, although I did still locum in the hospital in which I'd been working anyway, and that kept a hand in the clinical side of it, and meant that when the time came to come back, I was ready to come back. I phoned up my boss at the consulting firm and said, "Look, I'm planning to leave after this project, and my resignation." And they went, "Well, wait a minute, before you do that, um, would you consider doing one more year, but doing it in New York?" And I went, opportunities come. It's only one more year. How many times am I going to get a chance to work in New York? So I moved out there, and obviously it wasn't 1 year; it was more like 2.5. And had an interesting work and got to see the U.S. healthcare system, U.S. insurance system, and the consulting that I did was, I was a bit quant heavy in my stuff, so I really liked quantitative and math stuff. So I did retail insurance consulting, health insurance consulting. Got to see the world from that side, and then mixture sort of personal and personal reasons for family and stuff. I wanted to come back to the UK, so I came back, did my MBA, did another 5 years of consulting in healthcare in the UK and the US, and then at that point, I was sitting there going, well, maybe I want to come back into the health service. So I rejoined the NHS as the operations director for UCLH, specialist hospitals, doing a transformation role, really, to try and operationally transform the way that we delivered services across the hospital and then embedded it in an IT system. And in doing that, I got much closer to the IT world. I'd actually done a fair amount of programming when I was young, so even before med school, actually. So I'm just into the generation that did that, and it meant that I was equipped then to do a lot of these IT type functions. So I'd run various software teams. I'd done quite a lot of database coding and data management and manipulation and interpretation as part of my work. So back then, that would be what is now called data science, although I'm not sure we called it that then. And so I got involved in the IT world. I became the CIO of the hospital and the CITO, so Chief Information and Transformation Officer. Got involved in the innovation world. Again, did another operational and tech transformation at the Brompton, the way that we delivered care. And then look to do that at a slightly bigger level than an individual trust. So I'm now doing that across South London at the Health Innovation Network. So that's sort of the brief potted history of how from there to here. And that's, I guess I graduated now 25 years ago. So that's a 25-year journey.
Wow.
Martin, Yasmin, over to you.
No, lots to dissect there. Where do we start? Let's start with what you're up to now, maybe. So you're a chief executive, is that right, at the Health Innovation Network? Could you explain to us what exactly that is?
Yeah. So look, the NHS gets accused of not really doing innovation very well. And I'm not sure that's fair. I think we do innovation really well in specialist care. I think, if something comes up that appeals to, that kind of addresses the needs of your patients and it's more than 50% of your work, everyone gets their sleeves rolled up and changes what they're doing. Often, you need to work within the processes of a large organization, but that I think happens pretty well. So when we've seen things like hybrid closed loop come through now, we've supported the rollout of that to help hospitals get that in. But that's driven largely by the fact that patients want it and the clinicians recognize the value of it. And really all we're doing is getting some barriers out of the way and all the things that need to be wrapped up in that to get that tech out. That's at one end of the spectrum, and that's why I do it. But broadly, we do 5 things I think the bit that is hardest to do in the NHS in terms of innovation is when it's a small bit of your work. So if you're a GP and somebody comes up with an improvement that is, one patient a week, it's going to impact. How do you change all your processes to do that? And how do you keep up to speed with it? And so we're much more hands-on in that kind of environment. So we broadly do 5 things at the HIN, and we have teams against each of these. So we do health and care change programs. It's kind of what I was describing, something new's out there. How do we roll it out and how do we get it into the hands of all the clinicians and patients and actually get the supporting processes that are needed to make sure that works all the tech stuff, all the IG, information governance pieces that go alongside it, often the regulatory side, a whole load of stuff around procurement, all of that needs to fall into place. And I don't think any of it's all that sexy, but I don't think any of it's all that hard either. Do you know what I mean? It's kind of, but lining it all up isn't straightforward. And I don't think it's, you know, I don't think it's all that easy or difficult to do. So we do health and care change programs. We do a lot of work to support designing digital transformation. So the HIN South London that I lead has a focus on digital transformation, and that sort of plays to why my journey to this point as well. We also support innovators. So once you know, as part of the wider health and life sciences agenda, the government's always been trying to support companies setting up with innovations, either to improve health in the UK, improve the NHS, or indeed to go abroad and kind of improve healthcare abroad as well, and bring revenue back to the UK and pay taxes in the UK, obviously. So we support innovators, and that's often, if we have clinicians who choose to be innovators, which I think most of the listeners to this would be, often the clinical problem you're trying to solve. But there are other types of innovation, aren't there? There are often patients who've seen something that they want to change but don't know the health system as well, or engineers who've got a product that they see an opportunity for but want to test out, does that work? We do a bit of matchmaking of saying, your product's interesting, who might you talk to in a clinical setting? And for us, we link them up to South London, so often to people at King's, at St George's, at general practice, in community care, in mental health care. And I think that's often the way. So if it comes out of a university, there's an academic health science centre to help take that research knowledge and into turning it into a company. And we do two things. We say, here's what the health service needs in the region. So we do what's called demand signalling. And we do support for specific innovators. So those are the broad three things that we do. And in order to support that, there are two more things that we do. So in order to procure something in a publicly funded health system like ours, or like Denmark's, or any Canadian one, it's really important that we do procurement well. So we think that means you don't. In other countries, you might find that, or in other health systems, you might find that actually the contracts go to the friends of the people who work in that system, and money gets diverted in a quite unfair way. And in the UK, we try and be fair about this. So we run procurements. We say externally, here's what we need. We publish that. We invite people to bid for it, and then we choose kind of relatively dispassionately amongst things. Now, that's why the procurement systems are sometimes a little bit long-winded, but the aim of it is to make sure that it's fair and it's not people putting money in their friends' pockets with taxpayer money. So we in order to make that work, if you have a product and an innovation that you think works, you've got to have an evidence base for it. And that's an evidence base of efficacy, obviously, and we're used to that in the kind of training that we have. But actually, there's a whole set of other stuff that also goes alongside it. So you've got to have evidence that it's not disproportionately impacting certain population groups. So, things like pulse oximeters, do they read all skin types equally? And are there racial groups that that if we rolled out an innovation that would be disadvantaged by it? Are there health economic benefits to it? So often that's not captured with the efficacy benefits as well. And often that's dependent on which patients you're serving and which pathway you're changing. So my health economist colleagues at the HIN are always keen to stress that you always compare one thing with another. And again, that's another field that I don't think I learned that much about at med school, that I've learned so much more about since. And there are the careers in that whole space. And then we do a set of stuff around environmental sustainability measurement as well now. So, what's the carbon footprint change as we do things? And as we talk about a net zero health system in quite frighteningly short time, Actually, every innovation that we're putting in, we need to know, is it improving the carbon footprint? Is it worsening it? How do we choose between them?
Mm.
Um, and then also the social impact and the impact on staff. So I'm not sure that innovations that went out 10, 15 years ago, we were as sophisticated about saying, well, actually, is this making staff's life better or worse? So as we're doing things like rolling out ambient voice technology now, so products that you'll probably have seen around like Heidi and Tortoise that are
Mm.
doing listening into the consultations and helping write notes and things. See, a lot of that is focused on, is it not just improving efficiency, which is what people often measure, actually it's improving the quality of the consultation. Is it taking some of the cognitive load off clinicians? So I think that evaluation is super important. And the last bit is that we do quite a lot of work in capability building. And again, there are clinical careers in that space as well, which is saying, well, actually, how do we do QI? Is QI the right methodology? Is value-based healthcare the right methodology to change a pathway and system? How do we set up communities of practice so that as an area is evolving, what the clinical network that's supporting that change and evolution of services? So again, we manage some of those as well. So our aim at the HIN is to put together all the things that are needed to do the adoption and spread of innovation really well. And in some countries, you get academic medical centres which do that end to end. But in the UK, particularly because we have a split of primary and secondary care, and if we have chosen to have and we have the NHS, we've chosen to do it in a slightly different way, which is have academic medical centres producing research into companies coming in from outside and other ways of getting in there as well, and HINs helping all of those to try and or indicating what the NHS needs and helping the right companies to try and come into the NHS. So that's sort of the potted summary of what we do.
That's amazing. Really interesting to see how you take myriad of approaches to kind of support with NHS adoption of innovation and technology. I have two questions, but before I go into my question, which was more about your role within the network, I wanted to come across the comment you mentioned at the start, which you said in the UK, we don't do innovation as well. You said in specialist care we do it well, but we don't do it as well in the UK. And I just wanted to kind of pull that apart slightly. Why do you think that is? That maybe we don't do innovation as well in the UK, maybe compared to other countries?
Yeah, maybe I should have said as fast as some other countries, but if I were to so I worked in the US for a while, and about 5 years of my career I've been in the States, and over there, if you work in a particular field and you want to practice in a different way, you can kind of set up your own practice to do it differently, and you have to meet whatever the insurer is asking for payment. Alongside that is some self-payment, but you can choose a patient population and you can say, I'm only going to serve that patient population, and I'm not going to try and serve everybody in the country. I'm going to serve them, I'm going to do it in a certain way, and hopefully I'll have as good outcomes. And the insurance companies might ask you to demonstrate that your outcomes are as good. You can kind of set up and do anything, and it's on you to make sure that it's safe. Now, I think the flip side is that in the NHS, we have a lot of support to try and make it all our practice safe. But that also gives constraints, doesn't it, about what we're doing? And so with that support comes, if I want to change the service, a lot of people are going to ask me, well, how do I know it's going to make that's going to make it better? And you've chosen to do that, but it seems not to be helping these other patients over here. And are they going to get left behind? And so that whole bit of being able to just quickly deploy a particular innovation doesn't happen. And what then happens or it doesn't happen as easily. And then what happens in other countries is that that new service will either be taken up by everybody or replace what used to be there, and somebody will go bankrupt, and a hospital system will fail. And I've done turnarounds of hospital systems in the States as well. And in the UK, we don't really have scope to do that because we've organized our services in a certain way that's geographic and with single providers in particular geographies. So I don't want to paint the picture that it is necessarily better in other countries. It's just different. And as a result, innovation can spread into those countries quite quickly, but it doesn't necessarily serve everybody equally. It doesn't necessarily serve all. And in the States, you see that really starkly. I mean, I lived in Boston, and on my doorstep, I had 3 world-class hospitals. And I worked in a different bit of the US where the health system had fallen over because all of the providers except one had gone bankrupt, and that provider had then put its cancer prices up by 40%, and the local insurance company couldn't afford to insure people on low incomes for cancer care. So, it cuts both ways, doesn't it? And I think in the UK, I certainly, when I'm working with clinicians in the UK now, I get the feeling that everyone feels like innovation can't happen in the UK. But actually, I see it happening a lot, and especially in specialist care. There are constraints on that. There's funding constraints, there's constraints about how things are rolled out. But I think that many of those are deliberate, actually. We've chosen to do it a certain way that means that the pace of innovation is a little bit more measured, but that it's more universal. The aim is to innovate for universal coverage. And that's, I think, something we might have to revisit over the coming years as to whether or not that's necessarily the best approach. Does that answer your question, Yasmin?
Yeah, that does. And kind of then talking about the innovation and adoption of it in the UK, what strategies then have you found are most effective at accelerating the adoption of technologies in the UK, considering the regulations in place that obviously make it a bit harder to adopt? Right.
That's a really good question. So I think that when things get adopted really well, it's usually because there's an overwhelming clinical need to do it, and it's solving a clinical problem, right? And that can be a problem for the patient, it can be a problem for the clinicians involved or the administrative systems involved. But for something, particularly digital innovations, if I think about a lot of what we're doing now is around improving pathways, redesigning them, and digitizing. For that to happen well, you need several different groups of people to get on board, right? You need the patients and the clinicians who are kind of working out what is the right thing to do and what works best and how best to deliver it. Often you need the operational staff whose team we often forget, but their job is to make sure that it happens consistently and that it happens for every patient and nobody gets left behind. And often that means running 2 systems in parallel because of what I just described. So that needs to happen. And then the technology team needs to come on board. So often a new system needs to integrate with the existing ones and pull data backwards and forwards at the very least, booking appointments and which patient it is and what gets put into the notes, but often far more than that as well. And they need to check that data is held in a secure environment, which doesn't leak and doesn't give people access to different things and is resilient and, all of that stuff. And then the finance team needs to get on board because they need to work out how this is going to be funded and what the implication is. And if you're in a constrained budget environment, if I'm funding that, does it mean I choose not to fund something else? And almost invariably, it also means that by choosing to innovate in that space, I'm delaying the innovation in another space because there's limited capacity, there's a trade-off. And then you also often need some transformation resource because back when I used to teach medical students, we used to run through what is the pathway to deliver good orthopedic care and do a hip replacement and how many people are involved in that. And when you mapped it all out, from GP through to physio, there were about 55 people or roles that were involved, often multiple more people than that, but 55 roles. And there's a handoff at each because it isn't the same person doing it all the way through. And so all of that information flow, the organization that goes alongside it needs to match up. So the transformation team often helps with trying to work out what are the implications on the other people in that space. If I change something in the hip replacement pathway, perhaps that affects all the physios in the community. And the physios in the community are actually they might be doing mostly work on, patients with lung disease or something else. And this is only a small part. So thinking about all these kind of possible consequences and engaging the right people and making the change happen, that's what the transformation team would do. Now, to get all five of those to line up, that's a pretty complicated, in a big health system, pretty complicated job. And so that's why I find that's why I do what I do. It's like, who else other than people who've worked in clinical practice would you want to be doing all that work? And who? So that's how I got into it and why I find it exciting, Yasmin.
Interesting. Yeah. And I wanted to ask, as you said, so within your role, you have to work with different organizations. So whether it's like the NHS, whether it's the academic institutions, whether it's like local authorities, the innovators themselves. How do you navigate the different expectations and priorities of these stakeholders effectively?
That's another really good question. Well, so again, I think that's why it's really nice to have people who've worked in the system who do this kind of role. And at the Hin South London, we employ about 110 people, but they all come from different backgrounds, right? And we managing that kind of multidisciplinary team and a diverse group of people is interesting. But I think the main thing is curiosity. One of the things I found when I first stepped outside medicine into careers outside is before, well, first you're a lot older than the other people who are applying to do this job, and what other skills do you bring to it? And I used to say, well, over 3 years of clinical training and a few years of clinical practice, I totted up how many people I've met along the way, and I reckon that I probably talked to about 10,000 people by that point. And you probably heard the stories of 2,000 or 3,000 patients we ask a social history about what's going on, and we ask what's happening and how their pathway has worked and what worked and didn't work for them and whose input did they value. And often that's the OT or it's the social worker or social care at home and domiciliary care. So I think that's one of the bits that we as clinically trained people have a real benefit in, is that you hear those stories, and particularly medical students, because we probably get exposed to more of the breadth of all the things that happen in the health and care system than many other clinical professionals. And so I find that curiosity is the main thing which drives it, and listening to stories really.
I was just wondering as well, there's a lot of just from listening to you speak, there's a lot of different sort of operations that I'm guessing that you have to oversee, different sort of formats of work. And I was just wondering what percentage of that sort of is your clinical knowledge being used, and what percentage of that is all the different sorts of modalities of skill and knowledge that's required, and how have you got to that stage where you can sort of oversee all those different modalities of work and provide valuable input?
So I think there's probably two questions wrapped up in there. So one is around how I'm using my clinical knowledge, and the second is how do you do the chief exec job, because you've got to know what everybody's doing at the same time. So why don't I answer the second one first? Because chief exec job is a difficult one, because you've got to know what everyone's doing. I recognize that actually the specialists who are in my exec team know their areas better than I do and probably are up to date more. And you hire the right people for those jobs, and you kind of listen to what they say and you gently challenge them and work through. But I do think it is important to have the breadth of it. And I think that's where a bit of training in management consulting was very helpful. I say a bit of training, I mean, it was 10 years in the end, but it meant that I got to see, it's a bit like being a medical student in some ways. The consulting firms that I worked at did relatively short projects, typically 6 weeks to 3 month kind of projects. You got to see a different client each time. You got to see a different way of working, a different set of functions. And you worked with senior colleagues who knew their fields really well, and you learnt on the job. Until you suddenly were the person who knew more on that and were left to do it. But even then, you work the reason that the large consulting firms are quite interesting places to work is I specialize in organizational change and strategy, within particular industries. But I would often reach out to other colleagues if I needed to know about corporate finance or to think through some of the financial side. And so I think that balance of knowing enough about lots of things that you know the right questions to ask, and being deep in a particular area of knowledge is something that is valuable in medicine. It's valuable in other industries as well. And consulting gave me that breadth. And then I also did an MBA along the way, which I think gave me the structure and some of the content. But I think all of us would recognize from medicine, it's sort of the content changes from time to time. So you need to know what each subject contains. And then whenever you happen to need to know about it again in practice, you end up very quickly mugging up on it so that you're up to speed on what the latest developments are. So that's sort of the breadth and the knowledge.
If you,
and then I can answer the clinical question if you want as well. But
no, that's okay. If you were to do it again, my question now, and to get to this role that you are ultimately, would you do the same steps? Do you think those 10 years or so in management consulting really set you up for where you are now, or that MBA as well? Or how would you change it? Basically asking your advice for a medic now, if they wanted to get to your stage or your position.
Yeah. When I talk about my career now in the role that I'm in, it can sound like I made very active choices along the way. But I think the reality is I picked the next most interesting thing, right? And at every conversation or every group of things that you do opens up some doors. And there's an active choice. So I'm going to do this thing next, and it'll probably open up 3 doors along the way. And I don't know which is the one I'm going to go through when we get to that stage. So I don't think that this was the only career path that would have got me to here. And indeed, if I look at the other HIN leaders around the country, it isn't they all have very different backgrounds to me. And actually, I'm not sure you'd want 15 HINs to have the same kind of person at the head of them. So the answer is, this isn't the only way. Would I have done the same? Yeah, I think I probably would have done consulting, because I've made an active choice that was a good way to find out about the world outside medicine. It's quite hard to combine consulting with doing anything else, because it's a really pretty intense job, to be honest, or was back then. The hours were significantly longer than medicine.
Yeah.
And I learned a lot along it. So and it fitted with my life stage at the time, right? So I'm not sure that I would have made that switch if I had kids or was planning to have kids shortly. And indeed, actually, when my wife and I did have kids later, that consulting lifestyle did not work. So it's I think there are times that things work and things don't work. So I'm happy with my choices, but I'd recognise up front that it isn't the only way to do it. And the only advice I would give to people who are making choices is have a think about what are you going to learn through it, and is that there's the narrow bit that you're doing now, but is that going to be something that's useful down the line? And most of the medics I talk to are really good at that, right? And we see it in every industry. I remember there's a quote from Steve Jobs which said that he did a calligraphy course in his time when he was at university before he dropped out. And it's because he did the calligraphy course that the fonts in Apple looked prettier than the fonts in Microsoft, right? Because it was something that was useful, right? And if you surround yourself with people who've got different skills and different experience, then actually you get to a really great working environment, I think.
Yeah.
And I wanted to ask, for your experience in management consulting, what advice would you give to medics who want to explore that industry, especially balancing the locum work alongside if they want to kind of keep up their clinical skills against the long hours of consulting?
That's a really good question. I found it interesting to do a little bit of locuming work, but I'm not sure that I would recommend that as the route. So I think it's quite nice, especially if you're thinking you might go back at some point soon. But I did have a conversation with a clinical leader when we were both going for the same job a while back. And that person did observe that I was about 15 years younger than them. And I pointed out, well, it's a leadership role and a management role. And I've been doing it full time and you've been doing it half time. And so we've probably got about the same amount of management experience. And so I think there is a trade off between things if you try and split careers or you do a day a week of locuming or something else. It's sort of, my plan when I went into consulting was to do 2 years and then to come back to clinical medicine. And 2 years out was about what my educational supervisors at the time thought was doable. And I don't think they would have really been very happy about 3 years out. And what I found helpful about the locuming is that when I found myself at that 2 year transition point, when I was about to go back and they offered me this job in New York, I took the job, I considered the job in New York in the context of, well, I did some locuming last weekend and then came in to do the management consulting on Monday. And which one did I find more interesting? That side by side comparison is often quite powerful. And then the other bit that I would observe is that it is, depending what stage you step away from full-time clinical practice, it's quite hard to maintain your clinical skills on an ongoing basis, right? So when I talk to clinical leaders who now do 1 day a week of clinic, in one of my colleagues in another HIN is a GP, and he does 1 day a week of general practice and 4 days a week running a HIN. And he is the first to observe that he's probably not as close to the general practice as some of his full-time colleagues are. So I think you've got to decide which is your major and which is the one that you're using to support and maintain your relevance. The thing I would say about continuing clinical practice is that it's really helpful from understanding the relevance of what you're doing point of view. And I went back to clinical practice after a break of 7 years, back into a really well-supported environment. So I went back to AMU as a trust grade. And that was because I had a really interesting conversation with the educational supervisor. I want a trusted an environment where I'm supported, but I can only work out of hours and weekends. And they looked at me and went, so you can only do shifts at night and weekend? Oh, you can definitely find you a role there, I think. The reason I went back was I was putting in a clinical system and I hadn't worked in that hospital and I didn't know what the problems were and I didn't know what was relevant. And actually doing 6 months of an AMU job was, great. I was doing 2 days a week. It was good. So I think that it often feels like an all or nothing decision. And I think the long-winded point I'm making is that there are often routes back in if you're willing to take the status cut or the pay cut that goes with doing a job that you might have done 10, 15 years ago. And I think that's the sort of the relevance of that bit. I think doing consulting and locuming, I'm not sure I would recommend that, to be honest.
I love the idea that you said though earlier about kind of that comparison. For example, while you doing that locoming side by side, you're able to compare, okay, actually, which one do I enjoy more? Do I feel I get more of a reward from? Which then allowed you to kind of focus on the management side of things. And I wanted to ask, now that you've taken up leadership positions, how has your management experience influenced that? Because I think a lot of people get confused with what leadership is and what management is. So how did the two kind of interlink, or your management experience help them now with your leadership roles?
I think that's a really interesting point. And I think that, the two do get confused a lot, don't they? For me, management is about making trade-off decisions about what's resourced and how it's done. And then the operational decisions about how do you make things happen in a reliable way and a supported way. And the lead and some of the processes. And there's an overlap with some of the people processes which are there. But then leadership is about trying to identify, what are we doing, getting the right people on board to do that, creating the right environment for that, and supporting them as they deliver and helping coordinate what's going on. And so I think that's the distinction I would draw. And there's an overlap and a bit of a gradient between them, a spectrum between them, right? So as I've as my career has progressed, I do more of the second half of that than I do of the first half. But when I first started in management consulting, a lot of it was around, well, what's the mod? What is the optimum distribution of prices for something in a supermarket, or what is the best suite of healthcare products that a health insurance provider should be offering? And it was much more at that technical management end, and now it's much more at the kind of creating the environment for it. I do know colleagues who actually chose to stay at that first end and become really, really good at it and become specialists at it because they enjoyed it. They saw that they added a lot of value in it. It's not to say one is better than the other. I wouldn't encourage everybody to do the second of them, but I really love it, and it's a good way to have impact. But at the same time, I do occasionally, if you talk to my teams, I do occasionally say, "Can I just have a look at the spreadsheet? And can you show me how you did that?" And you don't want to micromanage, but at the same time, I do miss it a little bit.
Yeah.
And I think managing that trade-off at the right time in your career is actually one of the things that I've found hardest. And working out when to make that transition is something that I think is quite difficult for a lot of my friends and colleagues.
And when do you know when it's the right time to make that transition then? Kind of what key things you notice in yourself that made you realize, okay, I think it's the right now time to transition?
I probably made all of the transitions that I made 6 months to 18 months later than I probably could have done. So when you see some people who've got like stellar careers, I think they've probably done it by having amazing knowledge of that particular thing. If I'm enjoying what I'm doing, I keep doing it, is the gist of it. And then occasionally something comes up that sounds like I'll enjoy it even more. And so that's the way that I've made my decisions. I know others have been much more structured about it and planned it much better. And I can't really advise about which of those leads you to a happier life. Do you know what I mean? It's and the same is true in medical careers, right? Some of the best consultants I worked with had quite non-linear careers. I'm working with a care of the elderly consultant who had done dermatology before doing it, and therefore actually he prescribed a slightly different group of drugs because he had quite a lot of experience working with them in his dermatology practice in the States. So I think everything we do tends, if you throw yourself at it, it tends to make you more interesting. It's been my experience of it. And some of the people I find most interesting to talk to they've either gone really deep on something and know all about it, or they've gone really broad on things and have made connections between different things. And a few people have gone really deep on quite a few things along the way and made connections about them. And when you meet them, that's quite impressive.
Yeah. No, I like that. I asked that question earlier of how do you get to your position, but maybe I asked the wrong question. It should be more so, what do you enjoy on an individual level? And that will lead you to your dream job ultimately, or your dream sort of role. Because if you're trying to fine tune it and get to a certain end stage without sort of taking into account what you really enjoy, then maybe that's not where you want to go ultimately anyway. So yeah, and I wanted to ask you as well from your experience as an innovator yourself, but also his role is to oversee and bring up the best innovations and innovators. What, in your experience, has been sort of the cornerstone or the keys to success for those individuals who've succeeded as innovators, or their organizations have succeeded?
Mm, yeah, so I think that the challenge is something you said in your question, actually, which is the best innovations. Because I think even if you talk to some policymakers, you might get the view that there are 10 things out there that are amazing and should just be everywhere all at once. And that hasn't really matched my experience, which is that each health system, local health system, starts in a different point. And if you're in clinical training, you probably move from hospital to hospital and see slightly different problems in each, right? So I would say that the key bit is to have from a health system point of view, to have the right product to match the need that you have in that health system. And that means that from an innovator's point of view is to have a really clear product market fit for your innovation and to be able to identify who's going to benefit from that the most and to be able to support them. So I had a conversation with a colleague who had developed a really good medical HR platform and staffing platform and was trying to work out where to use it. And the question was, well, it does a load of stuff that the current platform doesn't. And you designed it that way because there was a need in a particular hospital. Did you check that that was also the need in lots of other hospitals? And if you think it is a need, how do you identify those hospitals and then identify the right people in those hospitals that it's got to get in front of? And how do you make that clear? And I think that the innovations which do really well are the ones which have got a really good product market fit. They serve a need. They've got a good product market fit. And the innovators themselves have invested in finding the right people and raising the profile of what they've done. And I've always held back a little bit from that. I think it's probably a bit of, the reserve of growing up in Britain is that when I talk to colleagues from the US or from other geographies, they're often quite loud about what they do and how they deliver it. I think we probably need to do a bit more of that. But what I've learned over time is we're doing it not because I wouldn't want to do it for self-promotion. I think I do it because that's how you get the word out about something that's great. And that's how we make the world better.
Yeah.
That's the ultimate thing.
Awesome.
It's a roundabout answer to your question, isn't it?
So, yeah, of course, product market fit and problem solution fit, massively important. And it just goes to show, even at the high level that you're at, that is a key aspect in any sort of implementation of anything, any sort of successful implementation. But apart from maybe the business acumen and the sort of scientific approach and doing that all right, what aspects sort of separate those successful innovators in terms of their individual values or how they conduct themselves or certain aspects about their personality maybe that sort of give them that edge in sort of innovating successfully? What would you say to that?
There are several schools of thought on this. So the reason I'm smiling a little bit is because if you put your scientific research knowledge onto this, there's a lot of the literature in academia on business has a selection bias towards the people who are successful. So the way you say, how did you become successful, is to pick a load of people who are successful and ask them. And that eliminates the people who were unsuccessful along the way and assumes that they were unsuccessful because they were less able to deliver stuff. I think that whilst it's true that the innovators who are successful are generally pretty good, it doesn't mean that you can't be good and not make it. And 80% of innovations fail, and some of them fail because the timing isn't right or something isn't quite there. If we look at something like Uber was massively successful. Halo happened just beforehand and wasn't, they aren't as big now, are they? But they were actually earlier. I don't know if you have iPods and things like that still, but they predated the iPhone, didn't they? But the iPod brought together a whole bunch of innovations for music. Prior to that, I'd had an MP3 player made by a company called Creative Labs, and that had been the go-to thing. So I think there is this bit that for the innovation to be successful, it really is about the right thing at the right time that meets a need and manages to roll out quickly. And so what I see in the innovators who are really successful is they have taken the time to do all that. And they also have quite extensive networks of people who they can talk to. And the same people you often come across at different points in your career. I still come across colleagues I was at med school with nowadays. But I think that the key bit is to build those relationships as you're going through. And then at a later stage, the serendipity is the relationship with someone that you had from long ago in an unrelated field. So I think that they're probably better connected and they probably better understand. The evidence from the innovation literature says the people who are successful have differentiated partly on product, but mostly on the relationships that they have and their understanding of the industry.
Okay.
And so finding out about the industry as a whole is the thing that will make you successful.
And how can medics and resident doctors, if they're interested in innovation and health tech, how can they find out more about that industry from your experience?
That's a really good question. So first off, there's a lots of related bits to it. So when I try and chunk it up, I tend to think in terms of pharmaceutical products and research trials that are there, med tech things and the engineering background that goes with it, and software and pathway change pieces that go with it. And you can go deeper into any of those three kinds of innovation, in my view. The pharma piece, I think there's a quite tried and tested way of doing it through research in universities and research in industry. But recognize that there's a lot around that as well. You know, there's a huge field around regulatory medicine and how the medical roles that are in there. On the engineering side, you know, again, if that's the bit that gets you excited, the engineering schools here in London have like really good programs to match up medics and engineers to try and solve problems. We have several of those here, and we have things like the London Institute for Healthcare Engineering, which runs programs. And then the tech side of it, again, there are good tech programs. So in your own hospital, if you were to approach the tech teams and say, actually, I'm a clinician and I'm interested in doing some shadowing or some work with you, I think most of them would bite your arm off because they don't often get people who do that. Increasingly, I think that's the case. But again, there's exposure as you go along. And I think some of that, you've got to think, well, what value am I adding to the company and am I serious about it? And if it's a 2-week internship, I'd do it unpaid. And if they're actually asking for a significant amount of time and you're adding value, then I'd ask for some compensation for it along the way. And then for me, the other path of innovation is not to do with those particular bits, but that last bit, the software and pathway change, I get really excited about the pathway changes as well. I think I don't know which, you know, most of us have been to a restaurant, right? I mean, there are these huge artisan restaurants that you can go to and do something amazing and one-off for you. And at the other end of the spectrum, the Subway, which feeds a whole lot of people and is the biggest restaurant chain in the world, right? Even bigger than McDonald's. But it does it consistently, pretty much whichever bit of the world you go to. And there's a spectrum in between. So, you know, I did a little bit of work in restaurants along the way, and things like some of the high street chains, you know, that do have consistency and recruitment processes and things. I admire a lot there. It's like that's how you get food to a lot of people. And I think we have to think in terms of healthcare. Which bit of innovation excites you? Is it the artisan, super complex stuff that you are really keen on? Is it making sure that the Subway end of the spectrum is delivered really, really consistently and well to every kind of person who's out there? I think we often make choices as we go about which patients we relate to the most and which ones we want to serve and help as we go through our careers. So I would say there's the content and there's also which patients we're serving.
Sorry, I love that analogy of using the restaurants to kind of explain the distributions of innovation. Go on, Martin, you go.
No, yeah, I was just wondering, also from your experience, so I'm just picking your brains because it's a good opportunity for me, but what sort of personality types or types of people are cut out for a role such as yours?
I'm not sure there's a single type because, as I say, there are different ways to be successful as a chief exec and in health innovation networks. So at the HIN chief exec level, the three in London all have doctors or ex-doctors leading them. But then we're different kinds of doctors. So one's a kidney doctor. I'd gone down the surgical route for a little while and quite interested in processes and how that works. Dominique's gone down a public health route and is interested in all things that relate to that. And outside of London, there are actually quite a few kinds. So there's someone who came from the pharma industry and really understands well how pharma products translate into clinical practice. There's at least one who came from a consulting background and understands lots about different kinds of health systems. So I think it's less about what I know and more about how I've managed to find a team that will work with me and recruit a team that will work with me and attract and retain them who have complementary skills to me. And so if I think the key bit is knowing what you're good at and what gaps you have and finding people who help you fill those gaps. And I think that's the key to it, rather than a set of things that are inherent in myself.
I think that's really important, actually, because the people you work with and the team you have can also really influence the dynamics and how you work. They talk a lot in terms of teams having that diversity. You don't want the same type of people within a team. Like you said, you don't want the same type of leaders leading different organizations, because you need to have people who have those different skill sets. And then if you build up that team who can complement each other's skill sets, that means you can drive innovation, you can make effective decisions together, which I think is very important.
Yeah, and also it just goes to show, like, it's not a one size fits all, as my question again may have been alluding to. It's everyone. I think it serves as inspiration as well to everyone who maybe don't see themselves as having the sort of quintessential leadership sort of personality type. I think everyone can have a space and make a space for themselves in terms of how they are individually. Yeah.
Yeah, so just to wrap things up, I just wanted to ask, what healthcare innovations excite you the most, and what's one change you'd love to see in the NHS within the next decade, and how can current med students and resident doctors kind of influence that change that you'd love to see?
On a tech side of it, I think there's a lot of focus on clinical products, and actually I think there's a load of stuff in non-clinical world that makes our ability to deliver care easier, or our jobs easier, or just make life generally better. So things like ambient voice technology I'd love to see rolled out very quickly, and I suspect we will. Whole set of stuff around HR processes. When you go from hospital to hospital, why can't I just take the documents? Why do I have to get them all checked again? Stuff. I think there's a load of stuff there that I'd love to see rolled out. And so I get excited at that end of the spectrum of medical innovation, which may be quite a long way from like cutting edge clinical practice, as well as the cutting edge clinical practice, obviously. But what I'd say is that on the clinical practice bit, there's so many things. It's like almost any specialty I look at, there's something cool coming, right? I mean, there's nothing stands still. And then your second question, I've now completely forgotten. So,
What advice would you give for med students?
Yeah, one piece of advice, a short, maybe 1 or 2 sentences, as to what you'd say to maybe your younger self as a med student or med students and resident doctors today.
I would have a think about why we're doing what we're doing, and think about the values, and then all the people that I would remind everyone that all the people you meet along the way, you will meet again along the way. Medicine is in the UK is there's a lot of us in it, but it's a relatively small world. If you treat people well, then it works well later.
Amazing. Thank you so much, Dr. for your time. I'm really grateful for your insight. And yeah, we look forward to seeing how your journey pans out.
Thank you. Nice to see you.